on the call here today, can everyone, can everyone just select that they're okay with the recording? Wonderful, thank you. So on the call today, we've got Sue and Julie, who are our research midwives, and they're sitting in the office at Guy's and St Thomas's in London. Myself, Katie Kirkham, the Senior Trial Manager. I'm based at Birmingham Clinical Trials Unit. We've got Ruth Evans, who's the Senior Data Manager, and she's in the office at Birmingham Clinical Trials Unit. And we've got Professor Laura McGee with us, who's our Chief Investigator. So, can you share the slides now, Sue and Julie?
Sorry. Oh, it's there. Okay.
That's great. Thank you, everyone. So we've tried to front load all of the information that the PI needs into the beginning of this presentation, because I understand that you can't stay for the whole, you may not be able to stay for all of the database training, but we'll try and get through as much as possible. So without further ado, this is the WIL site initiation visit. WIL stands for When to Induce Labour to Limit Risk in Pregnancy Hypertension. We are a multi-centre randomised controlled trial. We're funded by NIHR's Health Technology Assessment Programme. Professor Laura McGee's our CI, and we're sponsored by King's College London and Guy's and St Thomas's NHS Foundation Trust. We have a co-sponsor. Next slide, please. So this is an overview of all of the things that we're going to discuss in this SIV. We're going to take you through the whole trial, everything that you're going to need from start to finish, from getting you set up to actually recruiting and seeing patients throughout the journey on the trial, and everything to do with the database. So hopefully we'll cover everything and we'll get straight into it. So I have given you an introduction to the main trial team members who are all here today. But basically we do have two strands within our team. We have the Guy's and St Thomas's team, which is Sue Tohill and Julie Wade, and they are our lead research midwives, lots of experience in research and in midwifery. So they are generally your go-to people for clinical queries. If you have something that you're not sure about, if you're not sure about eligibility, or if it's an SAE that you're unsure of, usually Sue and Julie can help with most of those things. And they're the people that will contact your site on a fairly regular basis to check that everything's going okay. So please do stay in contact with Sue and Julie, and they will help you through the trial. So we also have the second strand, we have Birmingham Clinical Trials Unit, and we are sort of like the trial management group of the trial. So our team leader is Clive Stubbs. You probably won't have any dealings with him. It's mainly be me and Ruth who you'll be dealing with from the BCTU. And we deal with all the regulatory issues and keeping the trial ticking over, and any problems, you can always come to us as well. Ruth is your go-to person for any problems with the database or any data entry problems. She's there to help fix anything like that. Next slide, please. So this is how the trial is designed. We're a pragmatic parallel group open label multi-centre randomised controlled trial. We had an initial 9-month pilot at 20 sites, but now we're in the main phase and we want to include up to 85 NHS consultant-led maternity units across the UK. And we're inviting sites from the far reaches of Scotland down through to the corners of Cornwall. We want sites across the UK and Northern Ireland as well to take part. We're aiming to get 1,175 women consented in the trial, and that should give us about 1,080 randomised participants. And there's a discrepancy between those numbers because we expect that about 9% of women may deliver before they get randomised. So that's why there's a difference there. And we usually suggest that about 1 woman per month is your target for randomisation. But obviously that does vary quite a lot from site to site. And so it's really up to you to sort of think about your patient population and your research team capacity to let us know what you think that target should be for your site. So please do let me know when you've had a think about that. So our main phase started in July 2020. It started a bit later than we wanted to because, of course, that was when the COVID pandemic was in full swing. So our pilot phase actually ended in March, and then we had a short pause, and we restarted our main phase in July 2020. And we anticipate to finish recruitment in July 2023. And that would mean that the end of the trial, the proper end of the trial, when everything's been collated and reported on, will be January 2024. I'm just going to hand over to Laura for the background slides.
Great, thanks. So in the UK, up to 55,000 pregnancies per year are complicated by chronic or gestational hypertension. And so these women represent 1/3 of all women with pregnancy hypertension at term in the UK. So it's a sizable proportion. Now, we know that NICE in both 2010 and 2019 did not have clear guidance for us about timing of birth for these women. The recommendation was not to offer planned early birth before 37 weeks for women whose blood pressure was non-severe, unless there were other medical indications. And then after 37 weeks, the indications for birth should be agreed between the woman and the senior obstetrician. Now, current care at term involves maternal and fetal surveillance, delivery for clinical need based on maternal problems, fetal problems, or both. And we know most sites don't extend pregnancy to 41 weeks. Most of us get on with timed birth if these women are still pregnant at 40 weeks. And the variation in practice supports equipoise. Next slide, please. So this is a graph that helps explain the trade-off that we are trying to sort out. This is a figure from chronic hypertension paper. There was another group ran this analysis of routinely collected data in the United States for women with gestational hypertension and came up with the same conclusion regarding what the sweet spot is in terms of gestational age. But we had a figure in our paper, and so it just makes it a bit easier to understand. So if we first focus on the dark blue line that starts at 36 weeks and then see there's an elbow somewhere between 38 and 0 and 39, which is 39 and 0 to 39 and 6, because they're routinely collected data. We see it takes off, and then we see an increase in stillbirth with advancing gestational age. Maternal complications mirror this, although they were not examined in this paper. And so the hope is if we then move back from right to left, we can decrease stillbirth. However, if we now focus on the light blue line, that is decreasing with advancing gestational age. And again, it looks like it sort of levels off somewhere between 38 and 0 and 39 and 6 with regards to neonatal morbidity. And so therefore, it looks like there's a sweet spot somewhere between 38 and 0 and 39 and 6. And so that's where we get our gestational age parameters for the WILL trial. And as I say, it looks the same for gestational hypertension. Next slide, please. So we know these women are a high-risk group, but they're not always perceived to be this way if their blood pressure is controlled. We know that as they approach term, that they have an increased risk of complications for mom and for baby. So for mom, severe hypertension in up to 20% of women, progression to preeclampsia in about 25% of women with chronic hypertension, or 35% with gestational, because of course these women developed it earlier. We're not talking about women who present at 38, 39, or 40 weeks with gestational hypertension. And we know that this progression to preeclampsia can develop quickly without any symptoms, which is why we screen their blood pressure. And it's why women require close monitoring during expectant care, and why the WILL team thinks that planned early term birth might be better for mothers compared with expectant care. We also know that these mums are at increased risk of serious health problems in about 2% of women. Now, interestingly, across a number of studies, this has most commonly been blood transfusion, but of course, theoretically, it can also be eclamptic fits, stroke in the short term, or doubling in the risk of cardiovascular disease in the long term. For babies, we've discussed the increased risk of stillbirth with advancing gestational age, and the risk is about 1 in 1,000 by 36 weeks, which is the risk at 41 weeks for pregnancies in general, which is why we are now moving to offer timed birth at that point. Now, birth by cesarean is frequent, and care in the neonatal unit is also frequently required in these pregnancies. So they're clearly a high-risk group, even if blood pressure is controlled at the time. Next slide, please. And we have a training page trying to summarize these risks. This was in one of our newsletters, and we're working on a patient-friendly infographic because we've heard from our sites that this is a problem, that when blood pressure is controlled, there's a perception that there's no risk. Next slide, please. So we have very limited data to inform the care of women who would be eligible for WIL. We have 50 women in a chronic hypertension trial from 2014, and then at most 188 women with gestational hypertension in the group of women in the HIPPOTAT-1 trial with gestational hypertension who were enrolled between 37 and 0 and 37 and 6. And those data suggest that earlier birth at term may be beneficial to women with chronic or gestational hypertension without increasing the risk to their babies and without increasing the risk of cesarean delivery. Actually, it was quite really the opposite. But of course, the data are not definitive. The number of women enrolled was very small. The studies were conducted in Egypt and the Netherlands, and compared with the UK, there are differences in antenatal care, including less frequent use of antihypertensives, for example, in the Netherlands. Next slide, please. And there have been 2 reviews of trials for induction at term in non-hypertensive pregnancies, and induction was associated with a reduction in cesarean, which I will return to because that's our key secondary outcome, stillbirth, and neonatal death and morbidity, with no negative impact of induction on maternal death, operative birth, or postpartum hemorrhage. Next slide, please. And so this is a review. It's going back a while now, CMAJ in 2014, a standard typical picture with the vertical line representing a relative risk of 1. And you see that weeny little triangle at the top of the slide, which is clearly to the left of the relative risk of 1, reflecting a decrease in cesarean with labor induction. And its tiny little size reflects the amount of data that have gone into that estimate. And I put up this slide to show not only that induction has been associated with a decrease in cesarean, but it is done so across a whole range of subgroups. So regardless of method of induction, indication for induction, gestational age at induction, definition of induction, cervical status of induction, pregnancy risk, or parity. Next slide, please. So labor induction doesn't increase cesarean. The ARRIVE trial of just over 6,000 low-risk nulliparous women at term showed that induction at 39 weeks was associated with fewer cesareans and development of maternal hypertension. They didn't subdivide it into preeclampsia or gestational hypertension without an increase in perinatal mortality or morbidity. So why do we believe the opposite? Why are there still lingering concerns that induction increases cesarean? Well, outcomes following induction in the past have been compared with those after spontaneous labor. But of course, clinicians don't decide between induction and spontaneous labor. And unfortunately, that's not a decision that we can offer our patients either. So between induction and expectant care that may lead to either spontaneous labor or medically indicated birth are the choices that we have. And we'll expand that on the next slide. There's no evidence that maternal risk is increased by induction. And in a large RCTs, going back some time now, induction was associated with some positive outcomes. So more reassurance, less worry, and no perception of a decrease in maternal control during birth. Next slide, please. So now the NICE guidelines in development, this slide needs to be updated because they came out last Thursday, and I'm happy to say that the some of the awkwardness that was in the draft guideline has actually been removed. There is still no specific guidance for women with chronic or gestational hypertension, and Will addresses the first 2 of the 7 research priorities, that more research should be done to establish at what gestational age of induction of labor should be offered in the groups of women who may be more likely to experience adverse outcomes if their pregnancy continues. That's clearly our group of ladies with chronic or gestational hypertension. And we've drafted an information sheet that just highlights how Will fits in with the new NICE guidance, and that'll be reviewed by our trial steering committee and trial management group next Tuesday, and then hopefully come out to you for some feedback as well. Next slide, please. So in summary, there are no high quality data on which to base clinical decision making regarding timing of birth for this population of women. The Cochrane review says, more trials are needed. We don't have enough information, which of course the Cochrane reviews almost always say. That NICE continues to recommend discussion between the woman and her care provider, and so we need evidence, and we're really grateful that you are willing to join the Will team and help us answer what we feel is an important question. So thank you very much.
Thank you, Laura. Oh, hold on. So I'm going to go through the objectives and outcomes of Will, unless anybody's got any questions at this stage. If not, I'll just keep going. So the objectives of Will is to evaluate amongst pregnant women with chronic or gestational hypertension that develops by 37 plus 6 weeks gestation, the clinical effectiveness and cost consequences of 2 different time in birth strategies. And those 2 different time in births are either planned early term birth at 38 plus 0 to 38 plus 3 weeks gestation, or expectant care at term until at least 40 weeks gestation, 40 plus 0. And we're investigating whether planned early term birth can reduce a composite of poor maternal outcome without increasing neonatal care unit admission for more than 4 hours. We're also looking at whether it can reduce caesarean birth and whether it can reduce costs from an NHS perspective. So we have co-primary outcomes. So for the mother, we're looking at poor maternal outcome as 1 or more of the following: severe hypertension, so it's blood pressure equal to or over 160/110, maternal death, maternal morbidity as detailed there. And then for the baby, we're looking at admission to neonatal care unit for 4 hours or more. And this would be defined as greater than normal newborn care. So even if it wasn't admission to the unit, if you have transitional care where the mother is separated from the baby, that's what we would be defining as greater than normal newborn care. We have secondary outcomes. So one of the secondary outcomes is caesarean. We're looking at other maternal outcomes. So individual components of the primary outcome, preeclampsia, potential co-interventions, for example, maternal tests and fetal surveillance. We're looking at maternal ITU admission and maternal satisfaction. And for that, we're using the validated childbirth experience questionnaire. Also looking at other neonatal outcomes and health economics. So moving on to eligibility. So the inclusion criteria for Will, the woman should be 16 years or over, 16 years old or over. She should have a diagnosis of chronic or gestational hypertension. It should be a singleton pregnancy. She needs to have a live fetus, and she should be between 36 plus 0 and 37 plus 6 weeks gestation, and that she's able to provide documented informed consent. Now, just talking about the definitions of chronic and gestational hypertension, we're using the definitions based on the current NICE guidance. So that's chronic hypertension is defined in the NICE guidance as either hypertension diagnosed before pregnancy or a raised blood pressure before 20 weeks. And gestational hypertension is raised blood pressure at more than 20 weeks without new proteinuria. Just to note, just to say that women don't need to have raised blood pressure or be on antihypertensive medication at the time of consent. They just need that diagnosis of either chronic or gestational hypertension. Sorry, we've got the fire alarm test is every Monday at this time. Moving on to the exclusion criteria. So there shouldn't be any contraindication to either one of the trial arms. So you need to be, the clinicians and the woman need to be happy that she could fall into either timing of birth category. So for example, if she had preeclampsia, she wouldn't be able to go to at least 40 weeks. She shouldn't have severe hypertension. So if her blood pressure is more than 160, 110, if it becomes controlled, if it falls below that level and is maintained at a controlled level, then she could be considered for the study. But if it stays severe, then she would be excluded. If there is a major fetal anomaly anticipated that would require that her baby would need to go to the neonatal unit, that would be an exclusion criteria. And if she was participating in another time in a birth trial. So the only one we know about at the moment is the big baby trial, but we have worked a little bit with them, and we're finding that we're not getting the same population of women, so there doesn't seem to be any crossover at all. Just to mention that women with comorbidities, for example, diabetes, from the Will perspective, we're not excluding them from the trial. We would like them also to be in the trial so that the results are relevant to those, women with comorbidities as well. But you just need to be happy that she could get either arm. So I'm going to hand over to Sue, who's going to start you off a little bit on the participant journey.
Section of the SIV we're just going to go through together, myself and Julie, of the slide. So this is sort of looking at.
Just ask a quick question before you start the next bit.
Yeah.
Yeah. Sorry, because of fire alarm, so we missed that slide. We are excluding the preeclampsia. That's my understanding.
Yes. Because
urea and hypertension. Yes. Okay.
You need to be happy that she could equally, has an equal chance of going to the 40-week, at least 40-week arm. So if she had preeclampsia, I don't know anybody that would want her to go to that far.
Preeclampsia, anytime after 37 weeks, they will be offering delivery, isn't it? So,
yeah.
Okay. Thank you.
Okay.
So this sort of slide here just shows the database, but Ruth is shows our data manager, and she's going to go through database sort of training at the end of the slides. So this, she'll show you sort of like the home page, what happens, what you see when you log in, what all of the black toolbar that you can see of what all the tabs mean and which tabs that you'll click on to randomize, etc. So she'll show you all of that separately, and obviously what the forms on the database look like. For Will, we've tried to keep everything as paperless as possible, so you'll notice that you've got the CRFs in your site file, and they are really there for reference, and they show every single question that could be, and obviously the database, if you put yes to a question, it'll populate the questions that you need, and if you put no, etc., it'll do the same. So have a look at the ones in your site file for reference, and you also have the training database as well, access to that you can go on, have a play of all the the CRFs and make up women and pop them on, randomize them, etc. But I say Ruth will go through all of this at the end of the presentation. And again, what all these little boxes mean, and she'll go through all of this, what it means of the coloured little circles that you can see on the right hand side. So this is what we're just going to chat about now. So we're going to look at the confirming, as Julie said, about confirming that the woman does have a diagnosis of chronic or gestational hypertension to be eligible, assessing for eligibility. We'll talk about the obtaining consent and the methods that you can use for Will, the randomisation process, and then we'll go through the two arms. As you can see here, the planned early term birth, which is between 38 and 0 and 38 plus 3 weeks, or the planned expectant care, which is up to at least 40 weeks. We'll also chat about the follow-up prior to discharge, which is for the mother and baby, which is a childbirth experience questionnaire, and we'll talk about the follow-up at 6 weeks after birth. And as you can see there, it says about text message to the mother. So when we get to that slide, we'll explain what that means, and then the long-term follow-up. Laura, do you want to say anything about the long-term follow-up?
Sure. Just a comment that the box is in pink because it's not mandatory for you as a site, or of course for women. There is no long-term follow-up that is part of the WILL trial, but what we are trying to do is enable that follow-up should we feel as a care community that once we know the results of WILL, we have some concerns that would warrant follow-up, and then we would pursue additional funding. We're asking women in the consent form for 2 types of follow-up. First is a rather passive follow-up. So do they give consent to have their data, they're linked with other routinely collected data. So that could be long-term health outcomes. That could also be educational outcomes, for example, for the children. And then the second type of follow-up would be active. So if there's a hypothesis that that we feel should be pursued and that would require active participation, whether it's a study visit or filling out a questionnaire or anything of the sort. And so the permission that's being asked for there is for women to allow us to recontact them. Of course, they are under no obligation to participate. And I'm happy to answer any additional questions about that. But it's just about trying to maximize the usefulness of the data that we're collecting in WILL to honor the efforts that women are making, the efforts that all of us are making, and then of course the financial investment that NIHR is making in the trial, because each and every one of these trials is expensive. Thank you.
Thanks, Laura. So screening for WILL. So obviously, as Julie mentioned, the eligibility gestation is between 36 and 0 and 37 plus 6, but you know, a lot of these women you'll probably identify earlier in their pregnancy, which is fine. So it's always good to screen them, identify them, and approach them early in their pregnancy if possible. We'll talk about, as you can see here, that the consent to take part can be anytime from 36 and 0 up until the 37 plus 6. But we can't randomise them until they reach 37 and 0, and that's up to the 37 plus 6 weeks. So it's just thinking really about in your unit where potential women might be seen, you know, chronic hypertension, you may be able to identify those a lot earlier in pregnancy. It's looking at whether you've got I'm not sure at your site if you've got a dedicated hypertension clinic that you see women in, or if they just come to an antenatal clinic on different days or seen by the same consultant. And thinking of other areas like the maternity assessment unit. And again, obviously in the times that we're in, whether there's like virtual appointments, you know, where are these women being seen, how are they being seen, and sort of identifying them in those areas that they can sort of let you know if they've seen a woman with hypertension, and just so that you can go and give her any information. And for WILL, we have two forms of information that they can read. We have what we call the WILL introductory pamphlet and the main patient information sheet. The introductory pamphlet is a very short version. Obviously the main PIS introduces what WILL's about and if they'd like further information. That is a great leaflet you can give out to women if you've seen them very early in pregnancy, but any time really along the way, as long as they've read the main PIS before they take you know, you receive consent from them to take part, you know, use both of these leaflets. You can sort of send them out to women if you've screened sort of virtually and you've identified potential women. You could send out the information. We do have, if you notice in your site file, like a letter that you can sort of send out the introductory pamphlet or the PIS to them to read. With the consent form, you can attach them to your electronic systems if that's a way. So, you know, think of other ways that you can get this information to women early to enable them really to read about WILL and consider it once they get up to the 36 weeks gestation. We do have a screening, consent and what we call a key baseline variables form, and that's completed on the database for all women. So it just shows, you know, who you've screened, and it really is there if they are early that, you know, you can go back to them and update that screening form once they reach 36 weeks. And the study number for will is generated once that form is saved, even if they don't take part in will. And it's the same number that you would use all the way through. So if they did go on to consent and then randomise, it's the same number that's generated from once you've completed that form the very first time. And as we said, some women you may be screening earlier than 36 weeks, so you can still complete that screening form on the database. And certain questions will pop up to say, might this woman become eligible for will? And if yes, whether they're willing to be contacted once they're 36 weeks, up to 37 plus 6 weeks. And obviously what happens then once you've put those women on, you'll get a reminder email that's sent to you once they reach 32 weeks and 35 weeks. And it's really just a gentle reminder to say, you know, have you got any information at this point that you could update the screening form, or are you they're still okay at the minute and you're waiting until they reach 36 weeks. And it's always important to update that screening form, and a Ruth will show at the end on the database section. And it's just really looking at updating the screening date. So if you've put them on today and you go back to them in a few weeks' time, that you update that screening date, because it's like a new screen. Check all the responses that you've entered, update them. And for some of these, most of these women, really, it'll be that they might be that you've put them on earlier because you've given them information early in their pregnancy, and at that point they wasn't 36 weeks up to 37 plus 6, and so obviously just updating the responses. Remember, and obviously there's a tab on there that recalculates the gestational age at that point, and then it will ask whether or not she'll want to take part or not, and if she does, it goes through all the other questions that are on that form. And if not, you know, just ask for a reason if she's given you one to complete. So consent, as we've said, is from 36 weeks up to 37 plus 6. And for will, this can be received by a GCP trained midwife, nurse, or medically qualified member of your team that is sort of trained on will and named on the delegation log. And we'll go through on the next couple of slides about the methods that can be used. So there is obviously the in-person that you've seen the woman face-to-face at a clinic appointment, and you've gone through, make sure that she's obviously had all the information to read and she'd like to take part, and you can receive consent in that way where, you know, she's signing the consent form while you're present with her, and obviously you're signing it too. And if consented, sort of, as we said, at 36 weeks up to 36 plus 6, you don't randomise at that point. And if they are consented when 37 and 0 up to the 37 plus 6 weeks, they can be randomised at the same visit if that's what you would like to do. So the next slide will just talk a little bit about the remote consent methods. So this is obviously very similar to like being an in-person consultation, but you're contacting the woman by phone. And this is to discuss will with her, and obviously that's that sort of visit sort of virtually. It's also documented in her notes, and it's a time where you'll discuss the remote methods of consent with her, which we'll go through on the next slide. And if she's interested, you can email or post to her the main PIS, the introductory pamphlet if you want that at that point again as well, and the consent form just for her really to have a look at. And at that point, you'd also arrange a follow-up call. So, you know, when are you going to give her a call back? So really so that she knows, and it's convenient for her really, for that you can give her a call back. And during that follow-up call, it's really as it would be in a face-to-face consultation, answer any questions that she might have, and obviously to confirm whether she'd like to take part or not. And if yes, which method, if you're using a remote consent method, would she like to use? And we call those method 1 or method 2. And this slide will just briefly go into those. You have got a flowchart in your site file that explains this process as well, you know, so have a look at that too. So method 1 is where the participant signs. So the woman completes the consent form while you're on the phone. So you go through each point on the consent form with her, and she initials each of those boxes. And signs the consent form, and she will then scan or emails the completed form straight back to you while you're on the phone. If the woman's unable to sign the consent form with a pen at that point, it's also acceptable for her to type her initials and name as her signature. And in this case, it's just a copy, to file a copy of the email that she sends back with her completed consent form in your site file. So both of those, the site staff would receive the completed consent form, you'd print it off, check it while you're on the phone with her, and obviously you would countersign the consent form. Method 2 is where the site staff sign on behalf of the participant. And this is where you would have a witness that's present with you at the point while you're talking to her over the telephone. And that person, the person taking consent, obtains verbal consent from the woman for each statement. So again, you just go through each of the statements, but you would initial each box on her behalf and completes the consent form as the person taking the consent section. The witness that's present with you through that process also completes the witness detail section with their name, and obviously they'll sign it and date the consent form. And as you can see here, the witness doesn't need to be GCP trained or on the delegation log, but obviously we say it's better to have somebody that's trust employed, obviously because of confidentiality, etc. there. So whichever of these two methods that you decide to use, and obviously it's a choice between yourself and the woman, if you're using remote consent methods, you still need to email her a copy of the completed consent form for her to have and to keep. So following consent, as normal, it's just checking obviously that the consent form is completed correctly. The woman's study number is written in the boxes on the top of both pages. The last 4 digits of her NHS number is also there, her date of birth. Checking that the boxes next to each statement are initialed by the woman or by the site staff if using the remote consent methods. The signatures are completed correctly, the names are printed correctly, and the date. And any corrections, as you know, should be sort of dated, cross-through dated and initialed. So what do you do with completed consent forms? You can send those back to the Birmingham Clinical Trials Unit, and there are prepaid stickers that are in your site file. Or if you prefer to, you can scan and email the consent form to our nhs.net email account, which you can see on the screen there on the slides. And again, if you have a look through your site file, the details of our account is there, or please just ask us if you can't find it. So obviously legible copies of the consent form should be filed or forwarded to the woman herself, obviously in your site file at site. As we said, one back to the Will Study Trial Office at Birmingham Clinical Trials Unit and filed within the woman's maternity notes. And then obviously on the screening consent and key baseline form, there is a consent section. So there's a question that asks whether you've received consent, and if yes, then obviously the details come up to put in what sort of version of the consent form is used and the date of consent and the method of consent that was used for Will. And we do have GP letters, we have 2 of them, and one is a GP consent letter to say that the lady is taking part and she consented. And we also have a randomisation GP letter as well. We're skipping through, I don't know if you noticed on the other one, we're just skipping through the database screen because before Ruth would come through, but we're saving this, as we said, to the end there. So I'm going to hand over to Julie.
Yep. So I'm going to talk a little bit about reconfirming eligibility and randomisation. So consent and randomisation can happen on the same day if the woman is within the gestation of 37 + 0 to 37 + 6 weeks. So that is a randomisation window. So you can consent and randomise at the same time if she's between those. However, if you consented at 36 weeks, for example, you would, when it came to 37 weeks, you would need to reconfirm her eligibility before you could randomise her. So to do this, you would arrange to call or see the woman when she's at the randomisation gestation. And this contact is to confirm verbally that the woman remains well and doesn't need to be reassessed for an indication for birth, and also that she's happy to stay in the trial and be randomised. Now, when we say remains well, we're saying making sure that she has no new symptoms of possible preeclampsia, such as headache, visual disturbance, epigastric pain. We're also checking that she has acceptable blood pressure if she's doing home blood pressure monitoring according to the criteria that was set by her obstetrician, and check that she's got no reduced fetal movements or change in the pattern of fetal movements. So you would check and reconfirm that the baseline information collected at the time of consent has not changed between consent and randomisation. So you're just checking that that information is still correct. And then you would go on to the reconfirmation of eligibility and randomisation form. Now, you need to fill out this form for all consented women, even if you're not able to randomise her for whatever reason. So when you randomise, she will get allocated to one of two time of birth groups, as we've previously said. So either planned early term birth at 38 plus 0 to 38 plus 3, and this would be by labour induction, or if elective caesarean is already her plan, then it would be, then we're happy for her to continue with that, as long as it's within that window. The other time of birth group would be expectant care at term until at least 40 weeks. So if she got this group, she would still receive her usual care. She would be monitored and her birth would be planned on or after 40 weeks as per usual practice. Now, this is unless there's a clinical need that means that she needs to give birth beforehand. So obviously, any clinical need would take priority. And if there is a reason that she needs to be delivered before then that would absolutely need to happen. But otherwise, plan her birth for it can be at 40 weeks or beyond, as you would do normally. So following randomisation, there'll be an email confirming the randomisation, her study number, her time of birth group, and this email is sent to the site PI and the research team at that site. It will be sent to the individual who randomised the woman, and it's sent to Laura as CI and all of us as the central world team. Now, there is an additional baseline information form, which ideally would be done at the same time as randomisation. But if you're not able to do this at the time of randomisation, it can be completed later, but just enter the data as if you were doing it at the point of randomisation. As Sue said, there are two letters for the GP, and once you've randomised somebody, you would send the randomised GP letter. If you consented to randomise on the same day, then you just send this one. You don't need to send the consent one as well. We ask that you have weekly contact with the woman until she gives birth. And this is just to check that she's still eligible and wants to continue taking part. And we just say, if you could document that weekly contact in her maternity notes. So we're going to go to the database a bit later on. Just a few case studies where we've had cases where women were consented but weren't able to be randomised. And this has happened. So you might get somebody that's no longer eligible by the time you get to randomise her, and this might be because she's developed preeclampsia, she's had antepartum hemorrhage, she's had reduced episodes of repeat episodes of reduced fetal movements, or her blood pressure is not controlled by the maximum therapy. And we have had these cases. We've also had women that have changed their mind, or actually I don't think we have, but that's a potential. But we have had women that have gone into spontaneous labour before they are randomised. So some of these, so there's in will, we may have non-adherence where women may be delivered at gestations different from the randomisation group to which they've been allocated. And there are reasons for this, that this might happen. So what do you do if that does happen? So, for example, if the woman went into spontaneous labour before the allocated group that she was in, we would say we don't need to do a protocol deviation form for that. That is going to happen sometimes. So we would just capture that information on the delivery form. If there was a clinical reason for delivery, a clinical need that she needs to be delivered before the timing of her allocated group, again, that would just be information captured on the delivery form. If you're not able to book her in for her induction or her cesarean because of busy lists, we understand that that happens. It's a pragmatic trial. So again, that's information that's captured on delivery form. However, if the doctor looking after the woman or the woman changed their mind about the arm that she was in for no clinical reason at all, then we would ask that a protocol deviation form is filled out for this, and also we would capture that information on the database as well. But that would be an example of when we would like a protocol deviation form. Okay, I'm going to hand back to Sue.
So these are the follow-up sort of questionnaires for all randomised participants. So the first one is called the Childbirth Experience Questionnaire. This is a paper form that's completed by the woman and usually prior to her discharge home. And it just asks about her experience of her childbirth. Now, we know sometimes this might not get completed. It's a very busy time for the lady, you know, she's got a baby, probably desperate to get home, and it might not be completed before she leaves the hospital. So don't worry about that. It can still be posted to the woman for her to complete. You could actually, if your site texts to women, or you know, you can give her a phone call and say, would you still like to complete this? And then you can do that straight over the telephone with her if she's got time, or arrange a time, or if we said it can be posted out to her for her to complete. And as we know, this could be done sort of over a weekend, and some sites have been looking at ways that they, you know, how can they make sure the woman gets that to complete before she does go home, and they may have popped that in her notes or given it to her prior to her coming in for whichever arm that she's in. And some have said they've left like a box on the ward, you know, sealed box that the woman can put her completed questionnaire in, so it's obviously kept confidential, that no one else, it's not left on the side, it's put actually in a study box. So it's just thinking of ways that this would work at your site, but it is the paper form, and then obviously you would put the information then onto the database and keep this within your, as your source data within your site file. So the 6 weeks questionnaire, and this is sent to sort of women that are randomised by a company called Text Local, and that happens 6 weeks after birth. So the purpose of this slide here is really just to show you the text message on the your left-hand side that the participant would receive, obviously thanking her for her I can't even speak today, participating in the Will trial so far. And obviously, as per the consent form, it's just to ask about, to find out if she's had any problems with herself and her baby since they've been discharged from hospital after the birth. And this can be completed online at their convenience. And you'll see then they also have these options. Please let us know which of the following you're happy to do. So if they're happy to answer the questionnaire, they select that and it takes them through. There's only 4 questions. They do have some sub-questions to each one. If they answer yes, there might be another question that's populated, or no, there might be another question that's populated. But it doesn't take too long to complete. It's quite short. Or they prefer to answer the questions by phone. And if they select this, it means that they would like someone at your site to give them a call, and you'll be told about, you'll be letting, you know, there'll be an email that be sent to you that would let you know that this participant would like you to contact them to complete the questionnaire over the phone with them, and that can be arranged at a convenient time for yourself and them, and the answers can be put directly straight onto the database. Or they might select that they don't wish to answer the questionnaire at this point. So the 6 weeks questionnaires, obviously it's important to make sure that the correct mobile number is entered on the baseline form. That's the number that will be used to send the text message out to them. It's important that the delivery and the neonatal and maternal outcome forms are completed soon after birth if possible. And this is really with the baby's date of birth. And this is obviously to ensure that the text message is sent out on time at 6 weeks. Obviously, if there's a delay in that information going on, then there will be a delay in the text message being sent out. And it's also to check that all is well with mum and baby before that message is sent. The reminder text message the woman will receive is at 7 days after, 21 days and 28 days after the first text message is sent. And as we said, Birmingham, you'll be contacted after the 28 days if there's been no response. And this is really to ask you whether you're happy to contact the woman, to complete the questionnaire over the phone with her, or to post it out to her if that's what she prefers. And sometimes there might be circumstances where you're unable to contact the woman, and we still haven't had that information entered. And it can be obtained at this point then from her GP, and that's as per consent on the consent form. And as you can see, point 6 there on the consent form does say that she agrees for her GP practice being informed of her taking part in will, and obviously that she agrees that her GP may be contacted to obtain further information about any health problems that she has or her baby may have after they leave hospital. So this is obviously why you can complete the 6 weeks questionnaire at that point by her GP. But obviously we'll be around if you need any information if that does occur, and to help you. And we've got to a point where we have put a slide up for tea break, but obviously I'm not sure what time are we at. We're 5 to 3, I think I make it. So I don't know if anyone has any questions at this point before we move on, or you can ask questions whenever you have them. You can think of something you wanted to ask now that you think of a bit later on. That's fine too. So does anybody want a quick break, or should we carry on?
I've just got a couple of questions, but I think we're all right to carry on otherwise. Sorry.
If anyone wants to stop, just let us know, if you want a break at any point. But if not, we'll carry on then and see what happens. Yeah.
Let's ask some questions quickly before we continue. Hello.
Hello.
Can you hear me?
Yeah.
I just have a couple of questions and statements, and before I forget them. So, do we have our site number yet at all?
A site number? I don't think you get a site number.
Just a name. Just
Site
your
ID. Like site ID, and you don't
Just
have
the trust name.
no, just the trust name.
Yeah.
No worries. And then I just wanted to make a point about the original consent forms. So as our local practice, we keep the originals in the site file, but of course we'll put copies in the medical notes to the patient as well. But I just wanted to make a point because I'm not sure if it's this study where it references on the consent form that the original goes in the maternity notes.
It doesn't matter as long as all copies are clear. That's all. It doesn't matter as long as we get a clear copy at BCT, there's a clear copy in the notes, and you have a copy, then that's fine. Yeah.
Perfect, thank you. And then I apologise if you've already answered this query to my colleague Ruth already, but the reconfirming of eligibility, so that contact that's made for any women that consented at 36 weeks, can that be done by a research coordinator, because we don't have any research midwives at site?
Yes, I think so. What would you say?
Yeah, with confirmation.
If you're happy that they're happy to make sure there's no symptoms of preeclampsia,
Yeah.
so if you're confident that they're okay to do that, I think that's the main thing. Would be the
If we were unsure about anything a woman reported, then of course we'll go to our PI and the clinicians on the study team as well.
Yeah.
I think that was it. I did have one other, but I've already forgotten it. So sorry. Thank you.
Okay. Should we move on then?
Yeah.
So I'm going to just take you through a little bit about documentation and completion of data. So the documentation that we'd like you to put in the woman's notes is the date of approach and when you introduced her to the will trial, the method of approach, whether you rang her or if it was face-to-face, the version of the PIS and the instructive pamphlet if you did use that, date of consent, including the version of consent, method of consent, whether you use the remote consent or face-to-face in person, the name of the person receiving consent, name of the witness if you used that remote consent method, and then after she's been randomised, if you could document her study number and allocation. So there's also trial documents that we require for you to file in the participant notes. And this is a copy of the instructory pamphlet, if you did use that, a copy of the PIS, a copy of the consent form, a copy of any GP letters you sent out, and a printout of the email that showed you her trial allocation. So there are all the CRFs are on the database, apart from the childbirth experience questionnaire, which is on there, but that's given direct to the woman. So the CRFs on the database that you'll see The ones to fill out before she gives birth are obviously the screening and consent one, because you need that to document consent. There's a baseline one with baseline information, and then the reconfirmation of eligibility and randomisation form to be able to randomise her. After she's given birth, there is a maternal and fetal surveillance and antenatal care form, the delivery form with details of the birth, the maternal outcome and postpartum management form, the neonatal form, the childbirth experience questionnaire, and the 6-week postnatal text message, the one that Sue was talking about on the text message, that form's on there as well. Just to say, if the woman was only consented and didn't get to be randomised for whatever reason, you won't see the maternal fetal surveillance and antenatal care form, you won't see the childbirth experience questionnaire, and you won't see the 6-week postnatal form. So they don't need to be completed, so they won't show in the list of participant assessments. Also in that list, you might see, well, you will see, if you need them, a serious adverse event reporting form, a trial withdrawal form, and a protocol deviation form, if you do need them. Hopefully you won't. Now, I'm just going to talk a little bit about the maternal outcome form, because this is a form that may in some circumstances need verifying. And we ask this to be verified for the purpose of maternal co-primary outcome, of poor maternal outcome one. Now, on this form, there are 2 sections where data needs to be verified. And if you fill out a yes, or for either section, abnormal laboratory tests or maternal complications, there'll be a prompt to let you know that the data in those sections need verifying. So what you would do is you would complete the form, the research staff member would just enter the initial data and save the form. There'll then be somebody else who will review, verify, and sign off the data in that form. Now, this person should be someone who has not been involved in the care of the woman and does not know the group that she was allocated to. So it can be the PI, or it can be someone that the PI delegates that task to. And that person, so all you need to do is the initial staff member that's putting the information in, you could, when you get to that part, if you photocopy the relevant page or take a screenshot on your electronic notes, all you need to do is show the person who's verifying that information, redacted with any information that they're not meant to see, and then they would go on, sign on, and just put basically they sign on, and then to verify the data, they put their password in to say that it's correct. But we can, I mean, it sounds more complicated than it is. It actually isn't. It's quite an easy process, but we can go through that with you as and when that happens. And it's not for all women. It's only women where you have those 2 sections, information in those 2 sections. And we will show you on the database when we get to the database training. I'm going to hand over to Katie, who's going to talk to you a bit about safety reporting.
Thank you, Sue and Julie. Yes, so Will being an interventional trial means that we do have to report on SAEs and AEs. So I'm just going to take you through the process of that should you need it. So according to GCP, an adverse event is any untoward medical occurrence in a trial participant, which is identified at any point in Will. This is from randomization to 6 weeks postpartum and does not necessarily have a causal relationship with the intervention. So yes, from the points that a woman is randomized up until 6 weeks post-birth, that's our window for reporting SAEs. But we have been very, we've kind of selected which SAEs we're particularly interested in for the Will trial. So really, there's only a few instances where you would actually need to report an expeditable SAE, and I'll go through those now. So because of the high risk population of the women that are taking part in the trial, we do expect that they will have a number of SAEs. So we've split them up into 2 types within the protocol. We have the protocol exempt SAEs and our expeditable ones. So we only require reporting to BCTU if they are not protocol exempt, and I'll explain the difference now. Next slide, please. Thank you. So we have expected SAEs in this population of women. You know, we expect that we will have some episodes of preeclampsia. Some women will have PPH. There'll be some babies that are admitted to neonatal units. We are expecting to see that in this population of women. And so these are pre-specified outcomes. And we're capturing all that information on our routine case report forms. So we'll be collecting all that information as standard, and they do form components of the primary and secondary outcomes. So those are protocol exempt. Another example of protocol exempt are anything that's unrelated or related to the woman's routine care. So for example, admission for cesareans wouldn't be expeditable, or if they had hospitalization for worsening pruritus, again, it's not expeditable, it's protocol exempt. So what if you do get any of these, what do you do? So they do need to be recorded in your medical notes, and you do need to make a comment about the causality, and more information of that is in the will protocol for more detailed explanation of what the causality would be. But you don't need to complete an SAE form, and you don't need to report them to us. As I said, we will see them on the case report forms, and we'll analyse them as part of the outcomes. But if you do get an expeditable SAE, yes, hello.
Yeah, sorry, if you go back to the previous slide, please. Unrelated and related to the women's routine care. Admission for C-section, that part, what that means.
So normally in GCP, often they say any hospitalizations, any admissions are classed as SAEs. Okay. But so if a woman was admitted because she was having a cesarean, that wouldn't, in our case, it wouldn't be, you wouldn't need to report that to us.
And yeah.
Okay. So if you get an expeditable SAE, I'm just going to explain what the process is. So examples of these would be any deaths within the trial, whether that be the mother, or if there's a stillbirth or a neonatal death, or a maternal stroke. These will be examples of expeditable SAEs, but it's not an exhaustive list. So obviously if something untoward happens that you think might be expeditable SAE, please do let us know. We can advise you accordingly. But obviously these unfortunate circumstances do occur in association with chronic or gestational hypertension, but thankfully they are still rare events. But we need to assess their relatedness to the intervention, and that's why they're expeditable SAEs. So what you need to do, in the first instance, please give us a call to let us know that something has happened that you think might be expeditable SAE. You can either call Sue or Julie, myself at BCTU, or Laura if you need to, and we will help guide you through the process. And I think the next slide goes through that. So you should report the SAE within 24 hours of becoming aware of the event. Oh, I don't know what that, can anyone hear that? Oh, sorry, it might be just my computer. Sorry, you need to report the SAE within 24 hours of first becoming aware of the event. You report it to your trust in accordance with your local practice, but you also need to report it to the BCTU trial office. And there's a really simple way to do that. So you just log on to the Will Trial database, pop in the trial number, and you'll see that there is an electronic SAE reporting form that's ready on the assessments page for you to complete should you need it. So we'll go through that on the database training shortly. So you just click into the SAE form and you answer the questions that you need to answer. And as soon as you submit that form and save it to the database, an email will be generated, and that will inform all of us that there has been an SAE reported. And at that point, that's all you need to do. We will be made aware of it. So myself, I'll get the email, and also Laura as well. So anyone can complete the SAE form who's been delegated that duty on the delegation log, but we do need the PI to confirm some key details on that form. So first of all, the PI just needs to confirm that everything is correct and define the nature of the seriousness and causality of the event as categorised in the will protocol. And then you can just sign that off at the end with your password. And yeah, and it just gets sent straight to us. And also please document everything in your medical notes. And you need to follow up the SAE up until resolution or stabilisation of the event. So if you need to update your SAE form, if you've got new information to put in, you just edit the same form. You go straight into the same form and change the information on there. And that's it's as simple as that. And then Laura will categorise the causality and the expectedness independently, but it won't be downgraded. For any unexpected related SAEs that occur, BCTU will report them to the PI, the CI, the REC and the sponsor within 15 days, according to the regulations. So going on to trial withdrawal, back over to Sue, I believe.
Sorry,
we couldn't mute it then. Talking to ourselves, isn't it? Just a very quick slide here about trial withdrawal. As you know, in any trial, women are free to withdraw at any time, and this is after consent or randomisation. We do have a trial withdrawal form that Julie mentioned that's in the list of assessments required. And this is just a little snapshot of what the form sort of looks like, the section here, sort of asking. So it determines what information you can or can't use from the point of withdrawal. So you can complete after consent if the woman declines randomisation, and complete if she doesn't want her data used at any point after consent or randomisation. And as you can see by the questions there, you know, the first question was the woman randomised to will. This will then obviously, if you say yes or no, it will take you to the relevant questions for you to complete. To date, we haven't had any women withdraw from the trial, and we'd always say that if you're unsure whether it is actually a trial withdrawal or not, please give us a call and we can go through with you just to make sure that you don't fill the form out if you don't need to. And there is on the back of the form you'll see of your copy to have a look at, you'll see that once you've entered all the information, it generates what type of withdrawal that it is for this participant, and if it will also tell you that this isn't an actual withdrawal. So please have a look, and if you've got any questions, please contact us again if you're not sure or you need help completing this form if you need to. With the trial withdrawal.
What is that?
Database, but what we'll do, if that's okay, is we'll just carry on from this section for a minute and come back to it, and we'll just carry on with the rest of the SIV presentation that we've covered everything in one section at the end. So this is Laura, just to briefly discuss the pilot phase as well.
That's great. I'm just wondering if everyone could mute themselves. We seem to have some sort of kind of fuzzy background noise. I'm not sure where it's coming from.
I think it's a phone. I don't know if it's lighting on the phone.
Yeah. Okay. Great. Okay. So next slide, please. So we had, as is pretty typical of NIHR-funded trials, we had an internal pilot phase. This ran from June of 2019 to March of 2020. And we had 90 consented and 84 randomized women. We almost reached our intended analysis point, but this was the point at which, of course, the first wave of COVID struck.
We're
At that point, so we paused. Eligible, sorry, can everyone hear?
The background noise from wherever it's coming from is kind of drowning you
Yeah,
out.
I'm sorry. Can we just mute everyone?
Katie, can you mute? I think it's Ruth that's got control.
Really sorry, it's Ruth that has the control over that.
Yeah.
Ruth?
Ruth?
It seems to be, it's definitely that phone, isn't it? I think that's got the background.
Yeah.
What will they do?
Let's look at the participants. I think Ruth may have had to step away from the desk because it's really difficult to hear people. Can someone text her?
Yeah.
Yeah, great. Thank you. Shall I carry on? We'll see how we go.
Yeah.
Yeah. Okay. Okay. Sorry. So stop me if you can't understand or if the background is too noisy, because obviously as I'm talking, it's less prominent for me. So what we learned in the pilot is that eligible women consenting were about 40%, which is just slightly higher than what we'd estimated, and good for women in the NHS. And that the fewer than 10% of women who consented were not randomized because they required delivery, not because they changed their mind. And we thought that that figure could be up to 18% based on routinely collected data from the United States. So both of those were quite good developments. Next slide, please. But there were issues raised and that we needed to reflect on. And of course, this is why you do a pilot, isn't it? So that women may not be perceived, or they may not perceive themselves as high risk, particularly if their blood pressure is controlled and they feel well. And we've talked about that so far, and we'll generate an infographic to help with that, because of course they have underlying accelerated placental aging that is independent of their blood pressure, but reflects the underlying process that is both raising their blood pressure and increasing their risk of adverse events. Second, that there's a potentially negative perception of induction and potential co-intervention of membrane sweeps. And so we thought that while we rely on routine information that sites have for labor induction for our women in will, we thought that we should understand the information that they're seeing. And so we reviewed those pilot site labor induction leaflets, as well as a couple of national ones. And the will trial paper, here it says it's in draft form. It's been submitted to midwifery, and it's under peer review at the moment. It's been quite a good team building exercise to understand and understand local site context, because we're all within the NHS, but of course we all have differences between our practices. And some sites have used the process to revise their leaflets, and I'll talk a bit more about that in a minute. Excuse me. And then third, the exclusion due to contraindication to either trial arms. We saw that this was a main barrier. A major barrier, and the main ones were gestational diabetes, excuse me, or other major comorbidities. So a perception that these women may not be eligible for either trial arm. They are definitely eligible, excuse me, according to will eligibility criteria. And then the issue of elective section. So this is tricky, isn't it? So will is a timing of birth trial, not a mode of birth trial. Excuse me, but elective section, of course, packages timing of birth and mode of birth together. So we are very receptive to having these women in will, as long as you understand that they could be randomized to either one of trial arms. Just under 10% of women to date have been enrolled with an elective section in mind. Next slide, please. So this is the labor induction leaflet information that I alluded to. It was rejected by BMJ Open, so now it's with midwifery. Most leaflets discussed the why, the how, and the where of induction and the potential for delays, so all the sort of feasibility issues. But some of the information was out of date. So for example, often mechanical methods of induction weren't mentioned, misleading. So there was the implication that women could choose between being induced or having spontaneous onset of labor. Of course, that's never their choice. It's induction versus ongoing watchful waiting. some things were missing. So remarkably, the benefits of induction were presented in just a slightly more than half. And then almost all of the pamphlets presented as increases or decreases various adverse events rather than absolute percentages, which, and of course it's the latter we're supposed to use when we are counseling women. Now, membrane sweeping is usually presented as an alternative to induction, not a mechanical method of induction. And the new NICE 2021 labor induction guidelines actually now list membrane sweeping under methods of induction. Harms, well, induction's probably associated with more analgesia use, but inconsistently, and pain scores haven't been reported in the recent Cochrane review, so it's a bit murky. Certainly there were lower pain scores in the induction group in the ARRIVE trial, which is our most contemporary labor induction trial. Excuse me, with large numbers. And what about satisfaction? Where we have the data, women seem to be equally or more satisfied, but they do not appear to be less satisfied. So fairly, so identified some gaps and also some perhaps misrepresentations of the risks and the benefits. Next slide, please. I want to talk about the adherence report and just highlight a couple of things. So this is generated quarterly, and it's generated for all sites, and then you'll get your own sites specific information. So everyone gets an open access all sites report for the trial to date and then over the last quarter. Because if we're making changes, hopefully always improvements in our trial processes, then we want to see whether over the last quarter, we want some immediate feedback. Did it make a difference? Because of course it may just be too small relative to all of the women to date to see a difference overall. So you'll see this report. You'll have a planned early term birth column at the 38 and 0 to 3, and then a planned expectant care column at least 40 plus 0 or more. And then you have the randomized women. Of course, not everyone will have delivered. We have a very short randomization to delivery interval, of course, because it's all at term, but still some women will not have given birth for the report. But I just want to point out that what we're trying to track is gestational age at initiation of birth. This is the basis of our adherence, and you'll see here that adherence is very high, so it's in excess of 90% in both arms. And of course you're adherent if you deliver a woman prior to her allocated time for clinical need. That is adherence. And then we track gestational age at initiation of birth and gestational age at birth. Of course, the latter is the one we're really interested in. We want a separation of our trial groups, and we're looking for a week. We think we need a week in order to have an impact on maternal and perinatal outcomes. And this is the report to June 30th, but our September 30th report has just come out, and we're now 1.0 weeks difference with regards to gestational age at birth, so up from 0.9, which is really good. One other thing I want to point out is if you look at the last column, the planned expectant care at birth, I want you to look at the fact that there were 21 women who had spontaneous, whoops, if you could just go by, yes, 21 women who had spontaneous onset of labor, and then 61 for whom they had ongoing expectant ongoing expectant care, and then an intervention was required. And so although women in the expectant care group do hope to go into have spontaneous onset of labor, that's not on the books for most of them, for maternal reasons, fetal reasons, or both. Next slide, please. So this is, we're seeing the same patterns. And so this slide has slightly outdated data, but it's the same effect. These are the data from the screening form that we amalgamate and we use to track who's being screened, how many, what kind of women, etc. And what we can see here, just if you hit the next tab, is that when we look at women who decline, they're eligible, but they decline to participate in will, we see a preference for watchful waiting. So we see just over 10% prefer 38 weeks, 13% prefer 39 weeks, and 90 weeks. Goodness, I don't think anyone prefers that. And then just over half prefer either to wait for 40 weeks or not be induced. So there's a clear preference for the outcome that women are unlikely to have that I showed on the previous slide. Next, please. And so, and this is just summarizing what I showed you on the previous slide, is that about 3/4 of the women have labor induction or end up having an elective section, having been randomized to the expectant care arm. Next slide, please. And I'm handing over to Katie for the green light. I'm happy to answer any questions.
Thank you, Laura. So yeah, I'm just going to give you a brief summary of what's going to happen after this SIV in order to get you to green light. So obviously, this is the first step in the process, and we will. I think you've received everything in our local research pack, which includes the schedule of events, the organisation information document, and everything that you need in order to assess whether you can issue capability and capacity. One thing I just want to ask you to consider, you don't have to give me an answer right now, but really it's for your R&D department to let me know if you're happy with a site agreement that uses the organisation information document rather than an MNCA. And the reason why we ask you that is because the NICE guidance, the research guidance stipulates that for interventional trials, they suggest that an MNCA is more appropriate. However, our sponsor has deemed it preferable to use an OID for sites, if that's okay with each individual site. And the reason for that is WIL is a low risk intervention, and the intervention is part of standard practice, and therefore it was deemed entirely appropriate to use an OID, but the final decision rests with individual sites. So if you could let me know which one you prefer for your site agreement, and I can give you, I've got versions of either basically, so just let me know when you've had a think.
Hi Katie.
Hello,
hi, Katie.
hi, Lisa.
Just to let you know where we are. Hi, you okay? Yeah, just let you know where we are with that. So thank you for that explanation. I'm just looking into both of them at the moment, and I can give you a definitive answer this week on whether we want the OID or the MNCA. Brilliant. But with the MNCA, you are using it unmodified, is that correct? If we prefer the MNCA.
Yeah.
So if we prefer the MNCA, are you using that as unmodified? So you haven't edited it in any way?
So as far as I'm aware, it is unedited. I didn't draw it up myself. So but yeah, I think it's, I don't think it's been modified.
Okay, that's fine, but we'll give you an answer this week. Perfect.
Thanks, Lisa. So in order to get green light, there are a few other things that we need from you. The required paperwork, obviously we need the completed delegation log. We'll go through that in a moment. Also a training log. The SIV training forms the initial training for the trial. So just jot that down on the log and the people that have attended. We also need CVs and GCP certificates for all staff. Let us know, if you haven't already, let Ruth know how often you renew your GCP at your trust. Is it 2 years or 3 years? Whatever it is, just let us, just make sure that whatever.
Sorry, it's 2 years.
It's 2 years, perfect. Thanks, Lisa. So if you can just obviously make sure that everything's within that 2 year period that you send us.
Sorry, can
yeah. So there will also be the protocol signature page needs to be signed by the PI, and the site file acknowledgement form will need to be signed. That can be signed by any of the site team. There's also a version control tracker acknowledgement form that will be signed as well. And as far as localised documents go, Ruth will localise all of your patient-facing material as long as you send her the names and addresses and telephone numbers and logos that need to go on there. And Ruth will be in touch about that after this SIV. And straight away after the SIV, Sue and Julie will be writing a report from today with the information that we know about your site that you've completed in the pre-SIV form. And they will arrange a phone call with you in the weeks to come, just to make sure that there's no more questions from you, that there's nothing else we need to clarify. And so they will complete a post-SIV form with you, which you will then sign, and the PI has to sign that one as well. So just to go through the delegation log, because we really hate the delegation log in this trial because it forms a lot of it generates a lot of queries that Ruth has to get sites to correct or edit in different ways. So if it's okay with you, we just wanted to go through in a bit more detail to try and reduce any queries coming back to you, and hopefully it will be better off for you as well, because you don't have to keep editing and sending it back. So this is a copy of our delegation log, and it's pretty standard, but there are some pitfalls that sites fall into. So in the red box, we will need each person on the log to put their initials and their signature, and then the date that they signed, and that's what's in the red box. And then in the next few columns, in the green box, the from date will be the date at which that person started work on the trial. Then the PI must sign to confirm that that person is, that the PI is happy that that person is on the log from that date. And then the next column is the date that the PI signed. So it's a bit tricky. And if you're doing it in a hurry, I can see where, you can get it wrong. And we do get a lot of queries on these logs. So just be careful what you're signing for. And then just to highlight the actual duties on the log, please make sure that every single letter from A to K, or it's merely A to J are the main ones, every letter is delegated to somebody on that log. Next one along is to talk about maternal outcome review and sign off, which is letter I on the log. Now this refers to the maternal outcomes form on the database that Julie was talking about, where we need someone to independently come and review and confirm the outcomes that have been put on the database. So that person must be assigned the maternal outcome review and sign off on the delegation log. And we recommend that there's more than one person on the log, so that the person can truly be blinded to the intervention, which is as it should be, so that they're reviewing it, not knowing whether the woman was randomised to the earlier term arm or the expectant care arm. And then the purple box, please leave it blank until the delegate has finished the trial. So if the member of staff has left the trust or doesn't work on the trial anymore, that's when the last few columns will need to be completed. So please don't complete them any beforehand. And then at the bottom, leave that blank until the very end of the trial, that's when we'll ask you to sign that bit. So sorry to go through that, but it's just, hopefully if we can preempt any mistakes, that'd be great. And so here is some more guidance on the delegation log. You must complete it before any trial activities take place. It must be signed, dated and initialed by each delegated person, and the date of the PI signature shouldn't be before the delegate's start date. Every task must be covered, and ideally more than one person for maternal outcome verification sign off. Please, when you send us your CV and GCP, make sure that the dates are covered that that person's on the log for. And if you do have to make any corrections, it's absolutely fine. don't worry if you do make a mistake, but just strike through with one line, initial and date the corrections. So place the original in your site file and do send us a copy as well, because we do check these for every site, and then update it regularly when you get new staff. So if someone's not working on Will anymore, you can complete the last 3 columns with the end date, PI signature and the date, and only at the end of the trial should the PI sign and date the bottom of the page. So the training log, please keep it updated, add any new staff. You can use this recording as part of their training. Send a copy to BCTU. And anyone who needs access to the database must have had database training before Ruth will grant them that access. The trainer signature. For SIVs, a member of the central Will team will sign and return a scanned copy. And we're happy for site staff members to cascade training within the site. And if that happens, then the person cascading the training can sign the training log. If someone has self-accessed the training, i.e. they've listened to this recording or gone through the slides independently, then they can sign to say that that's what they've done. Next slide, thank you. Just a little bit about the PI responsibilities. So these are all taken from GCP, and I'm sure that it's stuff that you're already aware of. But obviously the PI is responsible for training the research personnel. They're responsible for the welfare and medical care of trial participants, the delegation of informed consent, the conduct of the study in compliance with the protocol, management of the intervention, the CRF sign-off, but that can be delegated, safety reporting, and the accurate and timely completion of trial data, archiving, and of course, if you go on extended leave, making sure we do have some cover. Just while we're on this slide, I'm just going to briefly mention that Will is part of the NIHR Associate PI scheme. And I don't know if you've heard of this, but it's a new scheme that NIHR have developed. The idea being that we encourage people whose primary role isn't research to learn to sort of be mentored by a PI, so that they can learn the role of being a PI, and they're termed an associate PI. And I just wanted to mention that in case you've got anyone in mind, or there might be someone that you can think of that might be interested in that within your site. It has to be someone whose primary job isn't research based, but it can be junior doctors, it can be other staff nurses or midwives that are interested in learning more about becoming a PI. So just putting that out there, and if you've got any questions about that, just drop me an email and I can give you more information. Next slide, please. So a little bit about data monitoring. There's 2 types of monitoring that we do for the Will trial. We do central monitoring, and occasionally we might do site monitoring. So I'll go through each type. But obviously the purpose of data monitoring is to make sure that the safety of participants is okay and that the credibility of the data is being upheld. And those are the 2 main reasons why anyone would monitor a trial. So when it comes to on-site monitoring or remote monitoring, that's when we're talking about that, it's mainly to do with source data verification, checking consent forms, checking eligibility, clinician oversight, site files, and that the clinical notes are reflective of what's in the database, so that source data is verified. But we aren't monitoring every site. We've said in our data, in our monitoring plan, that we only monitor sites once they've reached 5 participants, and we're not monitoring every site. So it might become relevant to you down the line, but at the moment you don't really need to worry about it. But we'll let you know if we do decide to monitor you for any reason. But just to let you know, we don't intend it to be a stressful process. It's more of a, we're here to guide you through it, and just you can come to us with any problems. Please let us know if there's anything worrying you about the trial, and we can work through it. We'd rather you let us know, you know, contemporaneously rather than wait for this to become a problem. But all of our monitoring at the moment is being done remotely, so there are no site visits at the moment. When I talk about centralised monitoring, this is the sort of thing that we do on a day-to-day basis, and we do it for all trials for every participant. So Ruth is our senior data manager, and she's the person that does most of this type of monitoring. So for participants, she will be checking consent forms. As Sue and Julie mentioned, we do want you to send a copy of the consent form to BCTU, and Ruth will be checking those carefully. And she also does checking of delegation logs and CVs and that sort of thing. And that's what we mean by centralised monitoring. We also do what we call data validation checks on the data within the database. So if there's any information on the database that perhaps doesn't make sense or conflicts with something else, then that will be picked up by data validation, and Ruth will quite often raise a query on the database, and we'll show you that in the training later on. Yeah, so please make sure your site file is up to date. I think Ruth has sent you a copy of the site file, paper copy, but just keep adding to it with anything that you need to put in there, and of course be ready for any audits and inspections that might occur. So study closure and archiving is very quick. We do need you to, so at the end of the trial, the CI completes the end of trial notification form, and we send that to the REC and the sponsor within 90 days of the trial ending. And then the summary of the trial report will be provided within 12 months of the end of the trial. With regards to archiving, the duration of archiving is 25 years after completion, which is in line with the guidelines for interventional trials. And we need you to archive any trial documentation, source documents, consent forms, obviously, you know, everything basically needs to be archived for 25 years. Just moving on to publication, and Julie, I think, is taking this slide.
Yeah, I am.
Thank you.
So at the end, the trial results will be submitted for publication in peer-reviewed journals, and we'll be asking sites to name staff who should be in the WIL study group, similarly to what we've done with the paper that Laura was talking about with the WIL pilot study group. We will be submitting abstracts to international medical congresses. Results will be on the trial website. Just to mention, the WIL trial website is a really good place to go for lots of documentation. All our newsletters and training pages are on there, frequently asked questions, so do look at that as well. And along the way, if you've got any ideas, please raise them for discussion, and we can definitely consider and discuss. Yeah.
Sure,
I'll
you
do
do
it. I'll do this bit.
Go on.
So just the support that you'll get from us throughout the trial. We do weekly update emails to let you know how the trial's going overall. We do monthly teleconferences and Zoom calls. We do newsletters, as you can see, that looks a little bit like that one there. As I said, we have the trial website. Training, if you need any additional training, as Katie said earlier, we're happy for you to cascade training, but if you need us to do any additional training, please do let us know. We have certificates of recognition, as shown there, that if you might want to give to any of your clinical staff or anyone that you think that has helped in contributing to the WIL trial in sort of referring potential participants. We have the WIL trial handbook, which has hopefully got all the information you need in there for anything. Please follow us on the Twitter page, at WIL trial, and on there, every time you randomise a woman, we will highlight you on our Twitter page as well. Ruth does some lovely pictures to go along with it on there as well. And then occasionally we send you some chocolates and things like that. And then finally, that's just mine and Sue's contact details. Please do get in touch If ever I'm not around, then Sue's around, and vice versa. So do sort of get in touch if you have any questions or need anything from us. And then just to finish off, this is actually Will, Laura's son. And I think, Laura, there might be an updated picture I've seen somewhere as well.
It's at the top now, isn't it? The
It's always updating now.
So this is who the trial was named after. So that's it. If anybody's got any other questions, let me stop sharing so I can see you all. There we go. Has anybody got any questions at the moment? I know we've had some as we've gone along, but if you've got any additional ones, let us know.
Maybe I could just make a comment that I think that we've tried, that there are many points, I think, at which you can choose how you would like to run Will, and whether it's the how you screen or how you consent, or how you adjudicate the maternal outcome. We'd like it to be as flexible as possible so that it can work as well as possible for you. And if you have any questions about that, or wish to, you want to be buddied up with someone who's doing something similar, let us know, and we'll do our best to accommodate you.
Katie, I don't know if you've seen, there was a couple of questions in the chat about targets and when starting. I don't know if you want to answer those.
Yeah, absolutely. So so when are you starting? Really, that's as soon as you can, as soon as you're happy to, as soon as you can
Yesterday.
get all those, yeah, as soon as you can get that paperwork to us. But we'll be guided by you, so please let us know when you're ready. And so there's no rush really, but as soon as you're ready, we will be ready.
So just
sorry,
this is Lisa, just an update from the R&D side at SAT. So I'm just working through the CNC approval process at the moment. We've just got a couple more local approvals to gain, and then I think we're in a good position. So probably not this week, but next week I would suggest we'll have CNC in place for you.
Fantastic, thanks Lisa, that's really good, really efficient. Really great, thank you for that. So but we won't hold you to it, but obviously that'd be great if you do get that to us so quickly. And as far as the target goes, I did mention it was about one, we do suggest 1 woman per month randomized, but really it's up to you to think about that and think if that's feasible for your site and your population, how many women you see that might be eligible. So have a think about that and let me know. You can set your own target basically. And your early talk, recruitment for women with, sorry, what was that question about, Shamila? Recruitment for women with PIH, PET and chronic hypertension.
Is that an eligibility question?
Oh, she's trying to connect to audio. Thanks, Shamila.
So while we're waiting, just to let you know the process, what we will do after this visit, I think we'll still do some database training for those that can stay on, but also I'll be in touch with Ruth probably, I think, to just go through if you've had any questions after today that have come up later, and we'll go through a few bits just to make sure you understand. Sorry, Shamila, are you connected yet?
Can you hear me?
Yes.
Oh, sorry, I'm echoing because I think I wanted. Can you hear me now?
Yeah, I think, are you connected by phone and computer?
So I'll leave the screen.
Oh, we lost her.
I don't know if that's her on the phone. I don't know.
It sounded like she was connected on 2 devices and she had feedback.
I do wonder if that's Shamila on the phone. that we can see there's someone connected by phone as well.
Shamila, can you hear us? And obviously she can't use the chat function if she's on the phone.
Can we unmute her on that phone, just in case you can unmute?
I'm trying to, and I've clicked on ask to unmute.
Just confirm it is Miss Sivarajan on the mobile. If she
Okay.
by audio, we're happy as a local team to touch base with Miss Sivarajan after about any eligibility questions she had, if she struggles to get through.
Thank you.
Thank you.
Thank you. So yeah, I think that's an eligibility question.
Yeah.
And so if there is progression, so we're recruiting women with chronic or gestational hypertension who are pulling up to term and who look like they don't have an indication for birth, they look good. But clearly if anyone progresses to preeclampsia at term, then that's an indication for birth. That is adherence with the will protocol. And we would expect that according to good clinical practice that women would be induced.
Great. So we're going to go on to database training.
Just wondering about how your recruitment's going so far. How many you've recruited together?
Who's got the latest today?
I have 233 randomised as of today, and 250. No, you put me on the spot now. 251 consented today.
Yes, so we're over the 20% mark.
Thank you.
That was last month we hit a new randomization high, so that was really satisfying. So we hit 2 milestones and a new goal and a new record. So that was really encouraging. So we're hoping for another really good month.
And we have lots of little milestones, don't we, that we like to reach along the way, and which site will it be that will do it? And you know, it's a team thing, it's the whole of the will sites, but we just do these little, we call them little competitions to see. We like to set things and, you know, make it a bit more interactive with you as sites.
We have monthly teleconferences, and we'll sometimes do Slido and take the temperature of an issue, and then everyone can see in real time who feels one way and who feels another way. And so we really do want to hear from you, your challenges, what's going well, your women who've participated in will for to give feedback and help to improve things for future women in the trial.
Thank you. Is Ruth still, Ruth, are you carrying on now to do the database training, or Ruth?
I have to actually leave because I've got to go pick up my daughter from nursery. I think Indusha and Sarah can stay, but can they have a 5-minute break first, because they might need to live.
Yeah, absolutely. Okay. Yeah. So 4 o'clock. Yeah. Should we start back again at 4 then? Do you want a sort of 10-minute sort of break? And I say when the follow-up call is done for the post sort of SIB report form, if you've got any questions, then it's always a good time, if you remember any, to ask, isn't it?
Brilliant.
Great. Okay, so whoever can stay for the database training, we'll see you back at 4. Go and have a wee and a tea and
I can do that.
Thank you. See you in a bit.
Sounds good. Thank you.
Bye.
Bye.
So Sue, Julie, Kate, so
Yeah.
I've got to go and give that diabetes talk. So, and it's at 4. So do you want me to come back, or are you okay with the database training, and you'll
we're
send
good,
me an
aren't we?
SOS
Yeah.
if there's something you need?
I think you've covered all the bits that we need you for. So yeah, feel free, go and do your diabetes training and enjoy the rest of the evening.
Thank you. Thanks so much.
Bye.
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 Hello.
Hi Ruth, I'm here.
Oh yeah, did you? I suppose you've been really busy. I don't suppose. Who was it? From somebody asking about stuff to put on the neonatal form about intravenous. Newcastle. Yeah, Newcastle.
Have you sent that in an email
Yeah.
today?
No.
Oh, okay. Oh, this was to do with the neonatal. They went to the
Yeah.
special care baby unit
Yeah.
for IV antibiotics. I think I need Sue to tell me the answer to that one. Can you hear us, Sue? Oh,
Listening. I wasn't listening, sorry.
oh, it's okay.
I was checking. I'm all right.
Ruth sent an email on Friday from Andrea at Newcastle with a query about a baby that required IV antibiotics administered on this SCBU, Special Care Baby Unit, is that?
Yeah.
I wonder if you could, she sent you the email on Friday, I wonder if you could help answer that query, because I'm not entirely sure what the right answer is.
Yeah, I'll have a look, yeah.
Thank you.
Have we got anybody back at station 6?
Space Station 6. Yeah, we're going intergalactic just to boost recruitment.
Yeah.
Did your niece due?
We've had another person on the associate PI scheme.
Brilliant.
We've just had an email through, and it's from Glangwili Hospital in Wales. And they've arranged an SIV with us in the next few weeks as well. So
brilliant.
That's good. So this is it's someone called Dr. Kumar. I think they're a junior doctor there.
Brilliant. Station 6, whenever if you're there, either talk to us or put your camera on. Nobody's there, they're all gone.
They're all write down things sometimes, because I don't know what I wrote it. There's not much people, I don't think, is there? Have you seen the cream one, did you say? Have you seen the cream?
So how many associate PIs have we got then, Katie? Just the 2?
So there's 2. There's the one I just mentioned, and then there's someone called Dr. Elgahi, who was from University Hospital Sussex, and he actually signed up in January, but because the scheme's only just gone live, we basically haven't spoken to him about it until now. So I emailed him last week to ask if he's still interested, and he said yes. So yeah, so we do have 2 at the moment.
Great.
Any joy with the PPI? Have you contacted them at all?
So we were
sorry. Sorry.
We were asking Laura about the contact that Peter suggested. And so I think today she sent an email putting us in contact, because we want to run it by them, run it by her, and then we can then proceed with the women we've got.
Yeah, brilliant. Absolutely, every email, so probably tomorrow onwards, won't we?
All right, I'll have to remember to cut this out, the recording.
Oh, we're still recording.
I forgot to pause.
Oh. Is anyone at station 6 yet? Is anybody back in the room at station 6?
I like that one.
Patience. It.
I like your jumper, Katie. I don't know if you. Oh, I don't know if you want to start from the beginning with the database, with the screening. Can you take the screen?
Yep.
Just go from like everything really, isn't it, that you'd normally do from the very beginning? Yeah, and through.
Can you see it?
Yeah.
Okay, so so this is the home page. And you just need to remember to select your site from the drop-down list. Okay, that just happens if you happen to be on the home page, the sign-in page for a while. Don't worry about it, just try again. I'm just gonna okay, so this is the home page, and then you'll see the number of participants you've consented and randomized. Obviously, this is very high because it's just a training database. And then from this page, you can run reports to check for overdue CRFs, but I'll come back to that. So to add up a participant on the Patients tab, just go Add Screening plus Consent. Then you just go through. And if the woman doesn't meet any of the inclusion or exclusion criteria, you'll get a warning message come up, but you just carry on and complete the rest of it. So this woman's 34 plus 2. So the answer to this one about gestational age is no. So obviously I can't consent to today, but I just carry on completing the rest of the form. So at this stage, if I put yes, I just want to show you the options here. So most of these are not exclusion criteria from the trial point of view, but maybe the clinician are not happy to let women be randomized into the trial. So anyway, just go through. If it's helpful to have the PDF of the screening form to hand, so you can see the different pathways. Anyway, at this point, I'm just going to put no. So eligibility that may change. Well, I'm going to put yes, because at the moment, the only thing that's making this woman ineligible is her gestational age. So obviously that could change. And then the next question, if the woman, so is this woman willing to be recontacted? If she's already said she doesn't want to take part, then at this stage you just put no, and then check through the reasons there and select those. I'm going to put yes now. So because she's 34 plus 2, when she reaches 35 weeks, you'll get an automatic reminder, email reminder asking you to get in touch with the woman and maybe and update the screening form. If you wanted to add the CRF notes, you can put in anything that's helpful to yourself. For example, when you're going to see her next or any plans. Okay, and then you just click save. And then the trial number is generated, and that trial number will stay with the participant throughout. So if she's consented, or if she's randomized, that will be the number she has. Oops. So if I wanted to edit this form, I'd click on the link here. It's only the first time you add the screening form, and then you can see the list of assessments that might need to be completed. So these discs here, they indicate the status of the form. So this is a new one, completion status pending. So by the every morning, the forms are refreshed if they've been changed. So that will change. That should change to green tomorrow morning to indicate it's complete. So it was just a change that was made on the database to speed things up, and it has worked. So you can see there, received, and then the other forms that might need to be completed. I'm just going to bring up, show you updating a screening form for somebody that was screened earlier. So I can put their trial number there, or alternatively, when you just log on, you can search for the patient in this tab, search patients, put the number there. But that sometimes can conflict with the NHS number. So I think the easiest thing, if you do know the number, is just to put it in, to click on assessments. So so this one was screened a couple of days ago. So whenever you need to edit the form, at the top of the page, you need to select an audit reason from the drop-down list. It doesn't matter which one, you just need to select one. I'm just going to get the NHS number there. So just go through all the checklist again. Actually, sorry, I need to, the important bit, update the date of screening. Check these criteria still apply. Click on calculate GA to update that. So now it's 36 plus 1. If, say, that when you came to update the screening form, the lady had already been given birth, then you would tick that box, GA not applicable, previously screened and now postpartum. Anyway, okay, so now I can change this to yes, because she's within that eligibility window. And just check through these. And because she meets all the criteria, you get more fields appear around consent. So maybe at this point you've recontacted the woman and she says she doesn't want to take part. So then you just select no and select a reason from there and then finish off the form. I'm going to say yes. And then you just select how she was consented. At this point, you're asked for the full NHS number. And then when she's consented, you're asked for extra information about her. So if I put yes there, then you get these fields appear asking you about all the different hypertensives. I'm just going to put no just to speed things up. And then I'm going to update the date of form completion to today. And then I'll just click save. And it will inform me that it's updated successfully. So just click on OK. And the next day, you'll get an email confirming the woman has been consented. I mean, that happens unless you randomize the lady on the same day, in which case you just get the one email straight away when she's randomized. I'm just going to go back to the assessments page so you can see how that's changed. So now there are due dates for these other forms because she's been consented. Okay, now I'm just going to look at randomizing a participant who's consented on a different day. So I'm just going to put I'll just put the number in there for now. Actually, I don't do that. Forget that. So to randomize somebody, from the Patients tab, you go randomize patient. So I'm going to put the number there. So this is what it will default to. So even if it turns out the woman can't be randomized because new plans have been made, it's important that you could complete this form so that we know why she wasn't randomized. So it says, was a woman consented today? If I put yes, it'll warn me, the woman, put me right, the woman was consented on the 6th of November. So I'm going to change that to no. And then it asks me, have any new plans been made for birth? If I selected yes, then I wouldn't be able to randomize her. I just click on there and just finish the form off. If I select no, then I get more questions about symptoms of preeclampsia. If I select yes to any of these, again, I wouldn't be able to randomize the woman today, and I'd get a warning message. I mean, possibly if she was just 37 plus 0, possibly things could change, and maybe a couple of days later you would be able to go back in via the randomized patient tab and randomizer. For now, I'm just going to put no to all of these. Yeah, be careful with this one. Try and make sure it matches. It's unlikely to have changed from a screening form, so just try and just check that what the situation was of the home BP monitoring, because you're asked on the screening form and on this form if she's consented on a different day. Okay, so you're willing to be randomized, put yes. So it's pre-populated with information from the screening form. Just have to put my name, and then again, and click randomize. And then you get confirmation there, and with the treatment arm. So I'm going to click on OK. And you'd also get an email almost instantaneously informing you of the trial number and what the treatment arm was. And that's sent to all the research team who have a database account. Okay, so I'm just going to go back to look at the patient assessments page for that person to show you how it's changed. So you can see there, it says date randomized. And now you've got the list of assessments is longer. So the additional ones are the maternal fetal surveillance and antenatal care, and the childbirth experience questionnaire, and the 6 weeks postpartum form, and then these other unscheduled forms that you might need to complete. Right, I'm just going, the only form that isn't in that list is the randomization form that we've just completed. So you need to access it via that tab. And then you can see, you can check there the group allocation. And to get back to the assessments page. I'm just going to click on there. Okay, I think now, is there any questions about that? Okay, I think maybe I'm going to look at signing the maternal outcomes form off. So I'm going to bring up a record for another participant. So this form's already been completed. I'm just going to change this because I'm going to edit it a bit. But first of all, I'll just scroll through. So there's some things selected in here, but these are the two sections that the PI or PI delegate would need to check and sign off. So abnormal laboratory tests and maternal complications. And because at the moment nothing's selected in those two sections, it's just the usual form completion section. If I do select something in there, when I scroll down to the bottom, you can see now there are extra fields. So what I would do is save the form, and then at some point when it was convenient, the PI or PI delegate would need to put their name in, put their database password in there, click on sign. That would the date there would autofill, and then they'd need to click save. But they would only have to confirm that particular section, the data in that particular section was accurate. They wouldn't have to check all the data in the form. Any questions about that?
Just the turnaround time. So have you got like obviously as ideally as soon as possible, but is there like a ideal or a cut-off for the PI or delegate to sign off this data?
I don't want to say no, but there isn't. We're patient.
Thank you. That's all right. I think we'll arrange to have like a weekly catch up anyway with the PI, so we're going to plan.
Yeah, I mean, yeah, we wouldn't expect it to be done within a week or I mean, if you look back, the due dates here, I mean, they're very generous. We only really sort of consider the form overdue if it's 4 weeks past. I mean, ideally, if we can get the data in as soon as possible, and you know, it's helpful. Just one thing, I'm sure Julie would have, or Katie would have mentioned it. It's important to get the delivery form and maternal outcomes neonatal form completed to confirm that the mother and the baby are alive and have gone home. Otherwise, the 6-week postpartum form, the text message won't go out to her until those things are confirmed. So it does make it, it does make it delayed. Okay, I think maybe I'll just open the serious adverse event form just to show you the different sections. Okay, so I completed this and I just save it, and then once I've saved it, an email will be generated to the site staff and to Laura and the central will team and Sue and Julie. And then as soon as possible, the PI or the PI delegate would need to complete this section, causality assessment. And then when they'd put their name in and their database password and click sign, then another email would be sent to indicate that it had been updated, and the next stage Then Laura would do her bit. And again, there'd be another email going out to say that it'd been updated. And then finally, BCTU would do this last bit. Any questions about the SAE form? Okay. Okay, well, I think what's left then is the data query management. So I send out regular emails every 4 weeks for sites to run the reports on the database to check if they have any active queries. And to do this, you go to this tab and click on Data Query Management Reports. An active data queries is the report that you need to look at. I mean, overdue data queries is the same, but it will just have the queries that have been overdue for more than 4 weeks. So it comes up with a table. It's ordered by study number first, then alphabetically by assessment. And you can see the question there and the instructions. Unfortunately, you can't just click on something and it will take you to the form. So you can export this if you wanted to print it, or you can just make a note of the numbers and then maybe, or you can just open another tab, which is what I'm going to do, and search for the patient's records. So there are queries there on the baseline form, and you can see it on the participants assessments page as well. In the left-hand side, it will tell you it's for unresolved queries, and the status is queries outstanding or missing data. So I'm going to click on that icon to open it. I'm going to select an audit reason. Doesn't matter what I select. And I can identify the questions that have queries by the question mark. So if I click on the question mark, it'll give me instructions. So most of the time it'd be pretty obvious. So please enter a phone number. And here's the query status active. So click OK. Just going to do that. And I just carry on. Now here, there isn't any missing data. So it's BMI 60.70. So here it says, this value is very high. Please check the values of weight and height. If incorrect, please change them and click on calculate BMI to amend, then save the form. So that's what I refer to as the edit and save form, because you're editing the form itself. If correct, please follow the manage queries process. So in that case, if you're not making any change, you have to go through a different process and update the table on a different page. So I'm just going to put OK. I'm not going to do, I'm going to leave that. I've checked, let's just say I've checked this and it is correct. So I'm going to come back to that one. Here's another one. These are the most commonly left out things. Please confirm all the above. Sites quite often leave those out. So it just says, please tick diet and please select a response for this question. Okay, so this question is about GDM. And we'd like, even if you've ticked oral tablets, we'd like you to tick diet. And I'm just going to put yes. And then the date of form completion. Now, for the BMI query, so it says, please follow, if correct, please follow manage queries process. So the manage queries button is down there. But if I click on that, it comes up with a warning. So are you sure any unsafe data will be lost? So obviously I don't want to lose that data I've just changed. So I'm just going to put no. and I'm going to save the form. So in this case, I have to address the queries in 2 stages. So now I can do manage queries, and I can click yes, because I know I've already saved it. And you get this page, the data queries page. And you can see the queries here. I'm just going to focus on this one at the moment, about BMI. Select it, and then you get more boxes below. You see the query again. So I'm just going to put checked and correct. And then I just put my initials. And I need to, this is the important bit, I need to change the status to pending resolution and click save. Because a common mistake is that sites will look at the form and say, okay, it's correct. So maybe they'll write something in CRF notes at the bottom, but then it won't register when I run the report that you've actually checked it and confirmed it. For these other queries, you don't have to do anything. It says active, but you don't have to manually go in and change all of these to pending resolution, because once you've logged off, automatically the status of those queries will change to pending resolution, because you edited the form itself. And I mean, I regularly run the reports for any queries that are pending resolution, and then I'll go in and check them and resolve them. Any questions about that? Okay, so every, say, 8 weeks, I will send a report, which is basically the same as a report you can run yourself, but it's just in case it sort of, sort of slipped people's minds. Okay, now I'm just going to go back to actually just one thing. Now, the 6 weeks postpartum form, I am sort of chasing via the queries process. I will raise a query on the sort of the form to advise you whether you need to try and contact the participant, because maybe she hasn't responded to the 4 text messages, or maybe she did respond and asked for a phone call and you haven't managed to phone her yet. It was just like a reminder. Anyway, so for the other forms, if you go on the home page, you can see here, so this one, there are delivery forms that are at least 4 weeks overdue. Obviously, you're not going to get this many, but you could check there, whenever you go on the home page, sort of like a reminder of what's outstanding. Again, sadly, you can't just click on it and it'll take you to it, but at least you can just make a note of the number. I think that's about it. Any queries?
Yeah, thank you.
And yeah, if you can, if you forget your password, from the login page, you can click reset password, and it will send you an email with a link to do that, or you can just contact the Will inbox, and then I can do that for you. Yeah, it's best to just, if you want to contact me, contact the Will inbox, because I monitor the Will inbox, and it's just in case if I'm off, because Katie will sort of have a look as well. So it's probably best to use the Will inbox email.
As you know, our Ruth had to go at 4. So in terms of her database training, of course, we're happy to go through the slides and train her up on anything she's unsure on. But if she would like a training link, did you say there was one available for the database, like a test database, I mean?
Yeah, so this is what I've just done the demonstration on, the training database.
We can have access to that if needed.
Yeah.
Perfect. Cool.
Yeah, and if you let me know if there's any other site staff who'd like an account on the training database. Yeah,
I guess it would only be so it only otherwise, other than ourselves here today, it'd be Ruth who would use the database for the entry, and then the clinicians would need database access purely for sign off.
Okay, so maybe they don't need training databases. I don't know.
Exactly. Yeah,
Okay.
if that's okay, if they don't need the full training, but obviously we can advise them on where they need to sign and enter their password.
Yeah. I mean, the other thing is you'll have this recording,
Brilliant.
so you can go to the database section.
Thank you.
Thank you.
Brilliant. Thank you, Ruth. So yeah, that's it really. So I'll be getting in touch at some point, just to make sure there's been no questions after you've gone away and thought about it. But yeah, hopefully we can get you open soon.
Yeah, definitely. I think we're nearly there. Yeah, like Lisa said, just final few things with governance, but no, yeah, we're good to go pretty much. So we'll let you know. We'll keep you updated.
Well, thank you for your time today. It's really nice to meet you.
Lovely to
Thank
meet
you.
All right.
Thanks, Em.
Thank you. Bye.
Good
Bye.
evening. Bye.
Thank you so much.